I'm Dr. Jam Kothari.
And I'm Dr. Sally Moore. And this is a Myeloma Minutes, a podcast for people affected by myeloma, patients, friends and family. Good evening, Jam. Here we are again, late night recording session for another Myeloma Minutes podcast. Now, this one should be quite interesting, shouldn't it? Because we're talking all about bone diseases, a nice follow-on from our session last week with Shahil. But before we launch into that, what's going on in your world? Any new bits of information to share with me or our listeners?
So the year is motoring on, Sally, isn't it? I went to Belfast last week, had a lovely meeting there. Talks about the controversies in the frontline treatment of myeloma, which was a great discussion, and controversial, and we'll get to those topics. But the nice thing was I was able to talk about the pod a little bit and advertise it to our colleagues in Northern Ireland, and there are also lots of people from the Republic there as well. So that was really nice, and we're heading into conference season soon, Sally, aren't we? We're going to be heading off to the European Haematology Conference in Milan in a few weeks, and lots of updates in myeloma to share soon.
Yeah, absolutely. There's so much going on. I mean, to some of our colleagues, it might seem like we go away rather a lot, but, you know, we need to, don't we? It's not like holiday fun time, is it? We are actually learning, and there's a lot to keep up with, which we'll pass on to everyone who's listening. So if you hear anything along the grapevine about any breakthroughs, let us know and we can cover it in this podcast.
It's definitely not like a holiday.
Definitely not a holiday.
I only allow myself one ice cream a day at a conference. That's very important. And on holiday, well, there's no limit, is there? But yeah, bone disease. So let's get into bone disease. It's probably more interesting than my ice cream habits. Bone disease, Sally, as you say, it's a very nice follow-on from the imaging thing. So can you just summarise for our listeners, when we think about bone disease and the treatment of bone disease, what are the main sort of areas that we think about and look at?
Bone disease is a really complex area, actually, and I think it's one of those areas where, as you work within the field of myeloma, the more you practice in this area, the more you realise there is to understand. It seems quite simple on paper, but it's actually, there's many layers. But in a nutshell, as we've discussed in our previous podcasts, bone disease is the process by which the bone becomes weakened because of the myeloma. Now, as we've discussed previously, this can happen in lots of different places, at different time points, in many different ways, and that can make it such a challenge, I guess. But it's important for us as the clinicians and the wider team looking after patients to really have our ear to the ground as to when the bone disease might be cropping up and in whom. And before we go any further, just to reiterate, Jam, bone disease doesn't happen to everyone, does it? It's a proportion of myeloma patients, a majority in fact, but not everybody.
That's correct. I think for reasons that are still poorly understood, some people don't get the bone manifestations of myeloma, but may be very symptomatic from other things. And for other people, bone disease is the reason that we know that they have myeloma, or we know that the myeloma is coming back. And of course, at different stages of the disease, bone disease can affect people in different ways in different parts of the body. So lots of things to consider. But broadly speaking, unfortunately, bone pain can be very painful. So pain relief and pain control is one of the key components of managing bone disease. And we will be doing a whole podcast on pain control, analgesia. Radiotherapy can be extremely effective at controlling areas of bone disease and has a number of important roles in the treatment of myeloma. Certainly in the spinal column, Sally, we can augment or improve bone disease by putting in cement into bits of the spine, or occasionally, this is done a bit less often now, you can put a balloon in the spine. And we will be getting a spinal surgeon on in the next few weeks to talk about this aspect of the management of spinal bone disease. But today, Sal, we're going to focus on one area primarily of the treatment of bone disease. And can you just tell us what we're going to mainly be talking about today? Yeah,
so we're going to be talking about how you calm down that process of bone disease and therefore enable the treatments to kick in to control the myeloma and hopefully allow the bones to heal. So as we mentioned in our earlier pods, one of the crucial drugs in doing this, which acts as what we would call medically an adjunct to your chemotherapy, meaning it's sort of like an add-on, but actually it's a bit more than that. But anyway, you can view it as an add-on because it sort of bolts onto most of the treatments we give, isn't the primary treatment itself, but actually can improve outcomes, as has been evidenced in clinical trials. And the drugs that I'm referring to, or the treatments I'm referring to, are in the rounds referred to as bisphosphonates, which is a bit of a mouthful, but they're the drugs that basically calm down that hyperactive state the bone goes into in sort of nibbling away at its own self, and limit that process to enable the bones to heal. So very clever drugs. Bone disease obviously affects lots of different diseases and cancer and osteoporosis and so on and so forth. So these treatments aren't only for myeloma patients, but we do use them in almost everybody we look after. Even actually, interestingly, patients without bone disease, because they still appear to have a positive impact on the myeloma. So that's what we're going to launch into today.
Normally in health, there is a balance between bone build-up and bone breakdown. And our bodies are so good at just keeping everything in check because bone, contrary to what I think a lot of people think, is actually a very active tissue. It's a very important tissue that lots of things are happening. And the very clever drugs that you've talked about are really good at trying to change the balance away from the cancer. So unfortunately in myeloma, that balance between bone buildup and bone breakdown is lost, and the body kind of goes into bone breakdown overdrive, and that leads to the holes in the bones, the fractures and the pain, and often also the high calcium levels as well, because the way in which calcium is managed in the body, one of this very important salt, the bone is a crucial part of that.
And these are one of those treatments as well, a bit like in our steroid podcast, which actually, when you've got someone who's presenting poorly with bone problems, with a high calcium, for example, which can actually, the calcium itself can cause problems like confusion or constipation, or can really upset how well the kidneys are working. You can pretty much in any hospital in the land get hold of this class of drugs, the bisphosphonate drugs, and begin to calm that process down, certainly in bringing the calcium down. And in doing so, helping the kidneys to recover, getting around any confusion that might be due to the calcium, and just helping the person to feel much more normal. So they're incredibly important, not just in that immediate setting, but also long-term too.
And we should also say that these drugs, bisphosphonates, are also more widely used in medicine in this condition, osteoporosis, where they have very, very wide usage as drugs that prevent what we call the demineralization of bone. So as people get older, especially in certain groups at risk, if you're a smoker, if you're potentially overweight, postmenopausal women, there's a whole list of people that are more likely to get osteoporosis. These drugs are very good at stopping and improving bone health and preventing fractures. So there are many different types of bisphosphonates. There are tablet types, there are intravenous ones. Their role is across lots of medicine, but of course we're going to focus on the ones specifically that we use in myeloma, Sally.
Yeah, we certainly are. And I think we're going to have to dial back a few decades, aren't we, to really look at really when the breakthrough was in terms of understanding how these drugs have such an important role to play in myeloma, which was in the UK. I think shout out to the UK researchers actually, who back in the 2000s did a huge study looking at different types of treatment for people with newly diagnosed myeloma. What they also did, on top of looking at the treatment itself, explored which bisphosphonates might be best, which might be best at supporting the bone or minimising bone complications, what they refer to as skeletal related events, which for us is basically fractures or bony problems. And they were really able to sort of lay the foundation for saying, actually, these drugs are good and they should be used in all myeloma patients. Jam, do you want to tell us a little bit about that study and how you understand it?
So it looked at whether a tablet bisphosphonate was as good as, or not quite as good as, an intravenous one, a newer one, which is more potent. But when a drug is more potent, it doesn't necessarily mean it's better. And it wanted to see, well, what are the differences in potential outcomes if you give the newer, more potent drug? And it was given once a month for actually up to 2 years. And the overall trial showed that the people that got the newer drug, the newer bisphosphonate, lived longer. And that trial has been the basis of us using this drug, Zolendronic acid. So this is the bisphosphonate that is used as really a standard of care around the world for myeloma bone disease, and we still use it today. But as the drugs in myeloma have got better, I think there is an understanding that we don't necessarily need to give maybe as much as we used to. But Sally, if we're now sort of focusing in on this drug, zoledronic acid, how is it given? And can you take us through, when you're starting a patient on it, what you do, what checks they need to have beforehand, and then let's maybe have a talk about the side effects of this drug as well.
Yeah, definitely. So it's very rare to find a drug which is what we call benign, which means it doesn't come with side effects. You know, we've all seen those big sheets of paper, even in your box of paracetamol, that lists all the problems that can occur. And the same is true of this treatment. And there's some things in particular, when I'm talking someone through starting this treatment, I really like to make sure that I've made clear. Probably the most important thing to say about zolendronic acid, however, is that to get the maximal benefit in terms of minimising further bone complications, you should start it as soon as you can. Now, it's recommended that prior to starting this treatment, quite bizarrely, you should go and see your dentist to have a dental review, which I'll come on to in a minute. But actually, particularly with people with newly diagnosed myeloma, it is recommended you just get going and do the dental review afterwards. But the reason why we recommend you should go and see a dentist is that there is a small chance that if you've got underlying dental problems, or particularly problems within the jawbone, which are increased if there are dental issues, then you could develop a rare complication of receiving this drug called osteonecrosis of the jaw, which I describe pretty literally as a sort of death of the jawbone. Suffice to say, it sounds pretty horrible, can be quite uncomfortable, but it's fortunately quite rare. That the way you lower the risk of that happening is through making sure your teeth are basically in good nick before you start the treatment. Just to go on to the latter part of your question, Jam, you give the drug into a vein. So you need a cannula to put in, obviously often in the back of your hand, and the drug is given to you or infused over 15 minutes. So it doesn't take long, but you still need to faff around with the cannulation. You need to have blood tests beforehand to make sure it's safe to give. But once you're hooked up, it's relatively quick. And it's also relatively cheap, which is why we can give so much of it so frequently. How often do you give it to your patients? Because this is quite a muddled area, isn't it, really, in terms of how, should we start and stop at 2 years based on that trial, which was done ages ago? Should we carry on with it? What's your practice?
What we now know is that modern myeloma combination chemotherapy drugs have anti-bone disease effects in their own right. So it's not just the bisphosphonates that help treat the bone disease. Like, the quicker you can treat the myeloma, the quicker you're able to get on top of bone disease as well. So I think it's clear that we don't need to give as much as we used to on average for newly diagnosed patients. There is, I think, a lack of consensus, but I think people generally think you probably need to give at least a year. Some people say you may need to give a bit longer, and they will still say that you should give 2 years, so 24 doses based on that old data that we were talking about. But we do know that actually with sort of cumulative exposure as well, other side effects can sometimes become problematic, and we should remember those. An important thing about zoledronic acid is that your kidney function has to be above a certain level to give it. And if you don't watch what you're doing, you can actually see people's kidney function start to get worse, and that can be effect of the drug. People need to be on calcium tablets because, we talk about myeloma causing high calcium, but a lot of our patients would have low calcium because of the effect of the zoledronic acid. So that's very important that they need to be on calcium and vitamin D. Patients can get like flu-like symptoms as well. So not everyone tolerates it that well. I think more people than we think say, I was fine, and then I had this drug and I felt dreadful for like 2 or 3 days. And then, potentially there are alternatives, which we will come on to. So I think it's important to be aware of some of those side effects as well. But in practice, for a newly diagnosed patient, I think one would say that you have to probably give it at least a year, and people will have a break over their transplant. But then, of course, when people relapse or looks like they're relapsing, then those agents should be started again. How long you use them for in the relapse setting, I think, again, it's difficult, and I think there is no sort of clear evidence to guide it. What are you doing, Sally, at the moment? What's your practice?
Yeah, so at the moment, I'm very much recommending for everybody who's newly diagnosed, they go on to receive it, or we offer it to them, and as soon as possible they have a dental review. and then continue it for the first year monthly. And then perhaps when they've achieved a remission, and by that I mean we're happy that the paraprotein or the myeloma or the light chain levels, whatever we're monitoring, is under control, consider decreasing to every 3 months. However, that comes with a caveat. This is not written firmly in any guideline everywhere. This is an intuitive approach rather than based on evidence. But I think perhaps one of the reasons for adopting this approach might be people are living for so much longer with myeloma these days. And so if you just carried on regardless, giving it to them every month, you could be going at that for a decade or longer. And do people really need that much zolendronic acid sloshing around in their system, particularly actually because it stays in the system for years? And so I think that's a pragmatic approach. And then perhaps when the disease gets going again, to go back up to monthly, particularly in people with bone disease. Although, Jam, I must say, I was reading in advance of this podcast, actually, I just did a quick literature search just to see if there's anything new out there about zolendronic acid. And actually, I did stumble across a study which was quite interesting, and it may give me a reason to review my current practice. And this is a study from Denmark, and it was basically looking at if you give this treatment every month for 4 years instead of 2 years, does it make a difference? And this one small study appeared to show that if you just carry on monthly, you might do a bit better. And by better, I mean fewer bone problems. So I think this is an area of interest. You'll talk to lots of different myeloma doctors and get lots of different opinions. There's no absolute right or wrong. The important thing is, I guess, for patients to have their voice in that consultation. Don't not go on holiday because you've got your zolendronic acid scheduled. And if you're struggling with it and having the side effects that you referred to, Jam, I would say, well, have a chat with your doctor about it. See how really vital it is. So that would be my overarching approach, to have a conversation with someone and see what works best for them. Have you got the same approach, or are you doing it a bit differently in Oxford?
I think we're using less in general. You raised some important points. I think the key thing is make sure you're on it if you have active myeloma, and make sure you're on the right supportive care around it. Like, are you on calcium and vitamin D supplementation, which is actually, a very important part of it. The dental review is important because, as you say, osteonecrosis is rare, but if you look at big series, maybe 5 to 9% of people get it. As you say, people are living longer, which means that they're going to see their dentist more often, and they will need extractions sometimes and other dental work done. And being on an active drug like zolendronic acid and having a dental extraction is a big no-no. So I think make sure you speak to your doctor and your dentist and make sure they speak to one another so it's very clear what dental work you can have done and can't have done. So I think those are all really important points. As drugs have got so much better, as in our other chemotherapy drugs, I do think we need less. And what I would say is that I think across the country, it would be good, I think, if there was a greater consistency in approach. And I do think there's going to be some sort of a practice paper or some guidelines coming out within a few months, which will help guide people's treatment. But I think, unfortunately, we've all seen people where it wasn't given for whatever reason, because it's just one of these things that was missed. So I think the key thing is just check you're on it. Check you're on it,
and and talk to your doctors about it. And if you want to have a break for whatever reason, I'm sure that could be arranged or your intervals extended. But I totally agree, Jam. When you've got active myeloma, that's when it's most important and should be considered.
We've talked about the kidneys and myeloma, right? And the problem is, of course, unfortunately, some of our patients come to us with kidneys that don't work and they never fully recover below a certain level, or other people may have kidneys that don't work for other reasons. So if their kidneys don't work above a certain level, they can't have this drug. So how do we treat their myeloma bone disease?
Yeah, that's such a real problem, isn't it? I mean, it's not the majority, but these patients are still incredibly important, and you really want to optimise their care, perhaps even more so because, there's a vulnerability that goes with kidney failure as well, and the activity of the bones. So there's a couple of approaches. One might be to try an alternative drug called permidronate. Takes a bit longer to give, but you can give that more safely in people whose kidneys are slowing down, aren't working quite as well as those who receive zolendronic acid. Or you could try the tablet form. Now, the tablet form, which was explored in that study we spoke about a few minutes ago, still works to some extent. Definitely better than nothing, but perhaps not as optimum as zolendronic acid. So there are other alternatives. They do come with compromises, like I say, the infusion time or perhaps not being quite as effective, but they should still be explored. I guess what I'd really like to do in someone with renal impairment is give them another class of drug called denosumab, which is very safe in renal impairments. It doesn't work in exactly the same way, but appears to be equivalent to zolendronic acid. But unfortunately, we're not able to do that yet. That's not funded in the myeloma setting. So those patients with renal impairment do require careful consideration, but there are options for them.
It's not funded in the UK, but in some parts of the world, you can use it for myeloma. It has a couple of key advantages. One is that you can use it at any level of kidney function, which I think is really excellent. And also it's given by a small injection under the skin called subcutaneously, so you don't need a cannula. So it's more convenient, and actually people could give it to themselves at home. And certainly for other cancers, for example, in breast cancer, it's available and can be used in the UK. And I think patients really benefit from that ease. And there's lots of studies showing that actually denosumab perhaps maybe even a little bit better than zolendronic acid. But I think the worst case scenario is that these drugs are broadly very similar in terms of the effects that they have on myeloma.
Just a shout out to some colleagues who may be searching for an alternative. It may be that you could have a chat with your clinical teams and just explore whether you might be able to get something like denosumab via a slightly different route. It can be prescribed for osteoporosis, for example. And so there might be some patients actually who don't realise they could receive that drug. And that might just be worth exploring on those rare occasions. So Jam, when you see someone in clinic and you're thinking about reviewing their zolendronic acid, let's start with that drug. What are you looking at? What goes through your mind?
So do they still have active disease? How long have they been on zolendronic acid? What the frequency is? And does it need to stop, continue, or do we potentially reduce how often we're giving it? So that would be one of the first things.
Do you think about look at their other medication? Is there anything that really, you need to check that they're taking?
Yeah, so we would keep a very close eye on the calcium levels. So even on calcium supplementation, people can get low calcium levels. And Sally, just briefly tell us the symptoms of a low calcium. People can feel quite rotten actually, aren't they, with a low calcium level?
Yeah, they can. It's not to be underestimated, is it? Because calcium is one of those molecules which is incredibly important. You think, well, calcium, what's the big deal in that? But actually it's really key, particularly for the conduction of the electrical activity within the heart. So that's almost the electricity in the heart helps your heart beat. And so actually if it goes too low, it can affect that heart beating process without scaring our listeners too much. But, it's certainly something that when you're seen in clinic, the doctors looking after you will be reviewing. But if it's not so low that, you need to have some treatment immediately to get around it being too low in case there could be a heart concern, you might just feel like weird tingling around your mouth and your lips sometimes, and just generally a little bit under the weather. So it's quite subtle. If there's a rapid change in your calcium levels, that's where the tingling and the funny sensations around the mouth in particular can kick in. But generally, I hope in most cases we get on top of it before any of those symptoms develop.
Yeah, and we just need to check people are on the right amount of calcium tablets to ensure that doesn't happen. And Sally, if a patient came to you, said, I'm on zolendronic acid, but my dentist said this tooth got to come out, it's infected, they had their last dose a couple of weeks ago, what's the guidance around that so that we prevent osteonecrosis of the jaw?
Yeah, really good question. I think it's important to say there's no absolute way of preventing osteonecrosis. If it's going to happen, it's going to happen. The measures we put in try and minimise that, but it can't eliminate it entirely. One of the things, however, that ideally should be explored before you start this treatment or soon after you started it is, do you think you need any dental work soon? And if you do, what will that look like? Because if you think, for example, you're going to need an extraction, which is basically, to put it simply, where you're taking the tooth out of the bone, so there is going to be some irritation of the bone, and they want to pause the zolendronic acid ideally beforehand. I say for roughly 3 months, have your tooth out, then another 3 month pause, start the zolendronic acid afterwards. I think that's largely what most people do. Again, I'm not quite sure where the evidence comes from there, but so far so good. I haven't had, not many people who've followed that path have had significant complications. So ideally you'd like to plan it, but in the case of an infection, it's benefit versus risk, and also how painful it is. Oh my God, to dental pain is horrible, isn't it? So if someone needs to have their tooth taken out and it's infected, then of course that needs to happen, but you would like to pause it ideally beforehand.
My wife's a dentist, so I can tell you that dental pain is horrible because she does not give me any local anaesthetic. And this appears to be descending into a therapy session. So let's move swiftly on. As we said, Sally, oh God, see, my listeners are really finding out everything about me now. So some people don't tolerate Zolendronic acid. So if they're not getting on with it and they still need to be on it, I would look initially at another drug called permidronate, which you mentioned. The slight disadvantage is that has to be given over a longer period of time intravenously, so it means extra time in hospital. And as you said, Sally, if you don't want intravenous treatment or you can't use it for whatever reason, the tablets still have some effect. And actually, for some people who are on tablet treatment who don't want to come into hospital, you can just add it in as a tablet, right?
Absolutely. You can just add that in on top and they take it at home, and I think that can work quite nicely. What's really important before we sort of wrap up this podcast, so Jam, just to kind of share with our listeners, as we did with Shahil, is that our listeners share any symptoms they might have bone complications, because it's one thing being newly diagnosed and that's how you present, with your myeloma. But once you're under a team, we should always have our eyes peeled for any complications occurring. And like I say, this supports minimising bone complications, but we all need to be in the loop together and be alert to any complications when they might be arising. And hopefully this treatment will help sort of nip those complications in the bud, so to speak.
Yeah. We've spoken about this subject in isolation, but in reality in the clinic, it's on our checklist. Are we managing the pain? Are they on these drugs, the bisphosphonates? Do people need radiotherapy? Is there a spinal thing that we need to do?
Yeah, Jam, I totally agree. Using bisphosphonates is one part of this jigsaw puzzle we're referring to, a really important part of the treatment modality, but not to be looked at in isolation. We also need to think about where the bone pain might be, how we can support improving a person's fitness and their mobility and taking away the pain. So there's a lot to consider around this. This is a really quick introduction to the sometimes quite confusing area of bisphosphonates.
Brilliant. Sally, thank you for your company, as ever. And we look forward to talking about further aspects of this in following podcasts.
Brilliant. See you soon. Thanks for listening, everyone.
See you soon.
Bye.
This has been the Myeloma Minutes. We hope that you found today's pod engaging, interesting, and above all, useful and understandable. Please remember that this does not constitute medical advice. Thank you so much for listening. Please do feedback on what you've enjoyed and what you'd like more of. You can email us at themyelomaminutes@gmail.com, and we'll see you at the next one. Bye.